It's a great honor to be here this afternoon. I've run into a lot of old friends and met some new ones, and I get a kick out of talking about addiction. I've been doing this for a long, long time, going on 20 years, practicing medicine for closer to 40. And it's only since I was doing addiction medicine that I was able to actually recognize the many different facets of addiction and how ubiquitous it is in society, medicine. I mean, it pops up everywhere. And so I'm gonna try and give an overview of addiction, and I want to tailor my remarks to this audience. Okay, first responders, EMTs, paramedics, how many? Okay, nurses, okay, nurse practitioners, okay, physician assistants, okay, pharmacists and PharmDs, okay, social workers and counselors, therapists, okay, physicians, okay, addiction medicine doctors, okay, got it. Basically, I suppose we ought to start with a definition of addiction. Anybody want to give me a definition of addiction? You got to shout. Okay, I'll give it to you for you. The official one is engaging compulsively in a negative behavior despite adverse consequences. Okay? So you can apply that to gambling addiction. Sort of funny that we're in a place that endorses gambling right now. For those of you that have compulsive gambling disorder, I suggest you make a beeline for the back door and get busy. I'm sure they also have a bar, so those of you that have any trouble with substances can make arrangements there too. But anyhow. So what it is the brain. Actually, gambling is a very interesting addiction. And the reason why gambling is a very interesting addiction is gamblers get a charge whether they win or lose. Right? If you're not a compulsive gambler, what happens is you get a buzz when you win. Right? Compulsive gamblers, when they lose everything, they still catch a buzz. It's a very scary addiction if you think about it. Anyhow, that one's a little bit different. A simpler definition of addiction would be doing something that's really bad for you and then lying about it afterwards. Right? I mean, anybody in here feel a compelling reason to lie about what they had for breakfast? Not really. Did you have the orange juice? You know, but when you start asking people, any heroin? You know, the answer will be no, but yet the urine drug screen may indeed light up positive all over. I'll give you another definition of addiction, and this one's a little bit more raw. It's a hole in the soul through which blows the cold north wind of life. I'm going to say that one again. Addiction is a hole in the soul through which blows the cold north wind of life. Okay. Now, it turns out that 80% of the population can drink or drug, and it doesn't matter. Okay, they may have some negative consequences. They may vomit a couple of times. They may get arrested. They may go to jail. They may end up with a spouse saying, if you come home doing that again, I'm done with this marriage. And they do really strange things, like stop. Okay, not my patient population. They pursue it to the very bitter end. But 80% of the population is like that, okay? Now, 20% of the population seems to have a great propensity to get into all kinds of trouble. And out of that, half of them will get into real trouble with drugs and alcohol. I'd like to thank Chris, the previous speaker, for taking half of my talk, by the way. Took all the statistics, but that's okay. I'll get even later. Now, why is that? Why does that happen? Well, it turns out that half of addiction is genetic and the other half is environmental. So for the same reason you got your eye color, for the same reason you got your facial bone structure, for the same reason you have your height, stature, and build, you also inherited a relative protection from or vulnerability to addiction. Okay? And so what happens is when the brain comes across the particular substance that it enjoys, what happens is the brain takes notice. Okay? And if we were at an Overeaters Anonymous meeting, you know, if I said the word cheesecake or chocolate cake or something, somebody would be salivating and having, you know, increased thoughts of that type of stuff. Okay? So the brain is coded for, be it cocaine, morphine, marijuana, whatever. And then the brain falls in love. And here's what happens. When people don't have trouble with addiction, take something like a Percocet, not uncommonly they'll do something like vomit and say, I don't want another one of those, please give me a Motrin. Okay? If you give that to somebody predisposed with addiction, here's what's going to happen. Oh my, I need the name of that one. That did it. Never mind that it might kill me. We'll put that one farther down the road. That's what defines addiction. And that takes place basically in a lot of places in the brain. Now, it's good to talk about addiction using the limbic system of the brain. The limbic system of the brain is like the oldest center, one of the oldest centers of the brain from an evolutionary standpoint. That's the part of the brain that we share with alligators. Okay? I mean, I don't know if alligators don't sit around reading Shakespeare. Can we agree on that? Okay, I mean, they're sort of nasty things. They snap, right? I mean, they're driven by things like food, the need to reproduce, and that's about it. I mean, they've got this drive for whatever it is. Well, it's the same limbic system that they have that made it into the rest of the animal kingdom. And it's been there for tens of thousands and millions of years. It's just the way that it is. And that is basically composed of a few structures. One is the nucleus accumbens, which is the pleasure center of the brain. When I was doing the walk across the front of the, what would be the days here, I was trying to demonstrate the buzz that would happen when the nucleus accumbens got hit by like norepinephrine, or dopamine rather. Now there's a few other structures that sort of project onto that. Okay, in the case of opiates, it'll be the periaqueductal gray and the ventral tegmentum and a whole bunch of other structures as well. But it's all linked together. And you inherit a relative vulnerability or protection from, depending on your genetics. Now, I mean, there's some interesting analogs inside the animal kingdom. I was on the same listserv that Charlie Burns back there belongs to a couple of months ago. And there was this one fellow that was talking about a terrible problem that happened in South Asia. And what happened was in an opium poppy field, where opium poppies were being grown legitimately for the pharmaceutical production of morphine, the production went way, way down. Okay? I mean, like it dropped by like 60% or something. And so immediately what the government thought was that somebody was stealing the opium poppies and selling it to make heroin. And the people that were actually toiling in the field says, no, that's not what happened. What happened is this bunch of parrots came in that happened to be drug addicts, and what they did is they wiped out the entire plantation. And they thought, well, this is ridiculous. That makes no sense at all. But anyhow, when actually the government went to inspect all this stuff, what they found was these piles of dead, rotting parrots next to these trees about 100 or 200 feet tall surrounding this opium plantation. What happened was this bunch of drug addict parrots showed up, wiped out the place, got too blasted. The ones that didn't, that weren't that addicted were on the, 10, 15, 20 feet off the ground, and they did not fall to their deaths. The ones that were really addicted would get loaded and then go up 300 feet or whatever, go on the nod, fall out of the tree and die. Now you would think that if you were a parrot, you'd get it figured out how to fly. You know what I'm saying? What I'm trying to give you is just the power of that drug, and it's not just in people. Other things get this too, okay? And it was interesting, was the response to that was somebody that had served in a base in Germany, and there were either bluebirds or blackbirds over there that would wait until the cherries fermented on trees to just the right level, and then they would sit around and get drunk on the fermented cherries. Now, if you could just picture a drunken, bluebird sitting around trying to get at a worm, pecking unsuccessfully for minutes, attempting to, I mean, you would think that if you were a worm, or if you were a bird, that actually getting the worm would be pretty easy, right? But they just get too blasted, they just can't do it. So my point is that this addiction is with us in one form or another across the entire animal kingdom. It's just the way that it is. And as long as we're on this, there are animal models for this stuff, okay? For about $5, you can get yourself a Fisher 442. Anybody know what a Fisher 442 rat is? They're friendly little rats. You use them for usually, experiments, and they don't overeat, they don't drink, they don't take drugs. They don't develop a lot of cancer, they don't develop a lot of diabetes and stuff like that. And they don't bite, and they're not prone to psychiatric illness either. But you can get them addicted. So if you put a cannula in their tail vein and you squirt them full of heroin or whatever it is, you can eventually get them addicted such that they will go over and push on the lever and take it until they're blasted. Okay? Now, if you take the Fisher 442 out of that environment and you put it with a bunch of other rats, other Fisher 442s, the thing will get healthy. Now, I have no idea what they're doing at night. They could be reading an AA book. They could be, I just don't know. But one way or another, the community of rats will nurse the thing back to health, and it doesn't relapse. It won't go back and start drinking and drugging again unless one of three conditions are met. You give it an unannounced priming dose of a drug in a tail vein. You put it in the same cage where the addiction took place. Or you subject it to a noxious stimulus, like a foot shock or something like that. Then the thing will relapse. Aha! Now we just have a model for people, places, and things, don't we? So if you take somebody in recovery from cocaine or something and you move them into a crack house or something like that, I mean, you can predict what's going to happen. It's very difficult for someone that is in recovery from alcoholism to go back to becoming a bartender again. Okay? The noxious foot stimulus type of thing would be the same type of thing as if you had a car accident or something like that and somebody put you on Vicodin or an opioid. The unannounced blast of fentanyl or whatever in the tail vein would be the same thing as having anesthesia, perhaps, after a femur fracture, and you're off again if you happen to be predisposed to addiction. Okay, so that's a Fisher 442. For a few bucks more, you can get yourself sort of a Nancy Reagan type of rat. I don't know how many people in this room can remember the just say no thing. Okay, well, these Nancy Reagan flavored rats, that's not what they're called. But anyhow, it's an easy paradigm to remember them. But these things just say no. No matter what happens, you cannot get them addicted. I mean, you can try and nothing happens. They just don't do anything. It's almost mealtime. I don't think I'd like to try any of that fentanyl. Might spoil my rat appetite. Won't do it. And then for a few bucks more, you can get yourself a Lewis rat. And these things are the darndest creatures you've ever seen. What they do is, having never been exposed to drugs or alcohol ever before, they will instinctively find drugs and alcohol and do it to the exclusion of food and water until they're dead. Okay, so now you have an animal model for the people that never drink and drug, the ones that can be exposed into it, okay, and the ones that will do it compulsively from a genetic reason. Now, half of addiction is genetic in nature, which we talked about, and the other half is environmental. Okay? If you can keep the brain away from drugs and alcohol until the frontal lobes develop, the incidence of addiction drops quite a bit. So the sooner that you expose the brain to drugs and alcohol, the greater the tendency to have addiction that is much more destructive. Okay, at what age do the frontal lobes develop in the human brain? Somebody?
22, 25.
About 25, 26 years old. Okay, and I mean, for those of you that have kids that drove you absolutely crazy, right? Because at the age of 12 or something, they thought that they knew absolutely everything and they had all of those hormones raging. What was going on? They did not have the impulse control of the capacity for higher executive function in the frontal lobes of the brain. But yet they had their limbic system and they had all of their hormones raging, and that's called adolescence, which every parent suffers through. That's why that happens. Okay, now. Now the frontal lobes of the brain are also easily damaged by these substances. And what's in the frontal lobes of the brain? Higher executive function. Good idea, bad idea. Right? Addiction, these addiction pathways that I'm talking about, and I might as well draw them. I was afraid that there would not be a magic marker. So I went next door in the speaker's ready room and I filched the nearest one I could find. You want to know where it is? That is the one that Dwight Gooden used for autographs. I'm sleeping with this one tonight. He has left the building, so it's not a personal possession, and I'm not stealing it. Okay, so here's the brain. Here are the higher executive functions in the brain, right here. Good idea, bad idea, impulsivity control, judgment, all that other stuff. Doesn't develop until age 26. What happens when you get somebody that takes a lot of drugs and alcohol? What happens to the frontal lobes of the brain? We have a radiologist here? You get frontal lobe pullback. What happens is it damages the frontal lobes. If you actually look at the imaging studies, you see a shrinkage in these areas. Okay? So what this does is, if you think a little bit more about this, what you have is the nucleus accumbens, which is the pleasure center of the brain, which is the aha function, right? Oh, snorting the ether was good. Drinking the chloroform, smoking the cigarette, whatever. And by the way, what is the single most addicting substance on the planet? Nicotine. Why? Number one, it's very, very potent. Number two, what it is very, very short-acting. So what it does is the addicted brain loves the spike up. That's why drugs that are very long-acting, which are the ones we use to treat addiction, at least for opioids, being methadone and buprenorphine, are long-acting. It doesn't pander to that as much. Do you see what I'm saying? Okay. So you got the nucleus accumbens, which is where dopamine will bang on it and it will go off, and it will have projections from the hippocampus and the amygdala. Anybody, what does the hippocampus do? Memory. Aha. So now all of these things are actually going back and forth this way, and it projects all up into here with the rest of the limbic system. And amygdala, what does that do? Anybody? Emotional memory. All of this stuff is interconnected, so you can start to see how stresses or exposures to past experiences or places will tip somebody off their sobriety. You got that? Okay. Now, everybody's born with these addictive pathways in the brain. It may be a little pathway or it may be a big one. Depends on your genetic slurry with which that you actually inherited. Okay? So if you think about a propensity for addiction, let's just say you have a high loading for addiction. You may start out with a fairly wide pathway through the woods. With more and more and more use of those pathways, and let's say you start at the age of 12, the youngest patient I had was 7, He started drinking at 5, smoking pot at 6, and it was the crack at 7 that really got to him. First thing we did is got him new parents. Anyhow, what happens is you end up with a narrow pathway in the woods, and then with more and more use, it becomes a wider pathway. Then after a while, it becomes a paved road. And then with more and more use, if you're predisposed to this, it becomes a superhighway with 17 lanes in both directions doing 250 miles an hour. Okay, that's what happens. Now, what happens if you just quit? You put up a road closed sign. The infrastructure is still there. Doesn't take much to go through a road closed sign if the 17-lane superhighway, whatever, is there as the infrastructure. So this also has to do with the failure of willpower. Okay? You'll run into people that say, typically in the lay public, that you should have more willpower to stop drinking or drugging. That works great if you're one of the 80% of people that don't drink or don't drug. Red light, can't go through it. Makes perfect sense, right? But what happens if you have troubles with addiction? It takes terrific willpower to be able to get $200 to $400 a day worth of heroin. Can we agree on that? Can we agree that going to visit 8 different doctors in 7 different states requires a fair commitment? That would require willpower. Can we agree on that? Okay, so if you think about it, it's not a matter of willpower because these people have terrific willpower. What has happened is the red light saying no flips green. Okay? Dave? Can't sleep. Bet you 4 Ambiens, half a glass of wine, and 2 Percocet would help. By God, that's a damn good idea. What just happened? Red light flipped green, right? If you got a bucket of willpower, what does that mean? It means you're off and running real quick. Okay? In that type of context, then some of the talk therapies or whatever that are used, and one of them that's most successful is a 12-step type program for alcohol more so than other drugs. But yeah, that's what happens. Okay, now, if you look at these individual things and we cone down on them, you end up with a neuron, right? So if you cone down the view, what you got is an afferent neuron and an efferent neuron. And this is the fundamental means of neuronal transmission. And what happens is an electrical impulse comes down here and it puts out bits of schmutz, medical term, of these various neurochemicals. And let's just say that this is a serotonin neuron. So in response to these electrical impulses, the serotonin goes out here, and guess what? It gets picked up in the appropriate receptors over here. What does that do? It then triggers this one. So anything that changes the release of these substances here or changes the conformation of these receptors over here will change neuronal transmission. In addition, anything that did the tidy bowl function, which is sucking this stuff out of there, will change it also. Now, there's actually an alcohol chromosome type of, the genotype for this is there's one variant of alcoholism that they have an overactive serotonin reuptake mechanism, and alcohol sort of paralyzes it. Okay, that's sort of the genotype for it. So what happens? That group of people, they take one drink, they feel normal for the first time. Now, if it just stopped at one drink, it'd be fine. But that's not the nature of the limbic system. Do you see what I'm saying? Okay. Now, the phenotype for that is early life failure, risk-taking behavior, and no harm avoidance. Wahoo! Bungee jumping with no cord. I can't wait. if they live long enough, they become your fighter pilots or your frat boys that can drink a quart of whiskey and still drive home because they're the most sober, at least walking, of the bunch. They usually have a higher tolerance to alcohol and other drugs, too. Okay? So severe alcoholics are less affected by alcohol, even from the very get-go, for this type of, all this stuff's genetic. See, this is not a question of theology. This is not a question of morality. Okay? Now, another thing to remember is that all of this stuff happens without the host knowing anything about it. What are the symptoms of pneumonia? Fever and cough. What are the symptoms of addiction? They're behavioral. Okay, what happens? Are the symptoms of addiction acceptable in today's society? The answer is no. No one wants to see somebody that steals your prescription pad, right? Nobody wants to see the patient that's trying to scam you out of drugs if you're doing internal medicine or whatever. Do you see what I'm saying? Now, I recognize that those behaviors have to stop. I got that part figured out. But please understand that they're symptoms of a disease. You wouldn't yell at somebody for having a fever or cough with pneumonia, right? So, I mean, when you see all of these odd emotions and they're very, very labile or whatever, those may be the symptoms of the disease that you're sort of looking for. Everybody got that one? Okay. Now, I have an incredibly simplistic mind. I apologize to anybody that may have seen this demonstration before. I don't use PowerPoint well. That's obvious. And by the way, if you think about when I was drawing the picture of the neuron, if you used like an electron microscope to actually cone down on the thing, and you looked at these receptors, you would see something like that. And when it got triggered by something that was appropriate, it would go off. Okay. But what happens if we change the conformation of the receptor? Do you see what I'm saying? You can either make it more or less receptive depending on what hits it. Okay, so if you actually cone down with another layer of magnification, what you may see is that. Aha! I found a benzodiazepine receptor. See what I'm saying? That changes the conformation of the receptor. How about that one? Oh, my. Found a barbiturate receptor. Okay, you're changing the conformation of the thing. That's what happens. Okay, now if we go back to our model, now I have a friend too that, my friend Mario from Western New York State. It's not the Mario that Charlie knows, different Mario. And what he did is he was educated classically in Italy, but he smoked Gaulois cigarettes. Anybody here ever smoked Gaulois? They're incredibly strong. 2 puffs. Oh, Dave, you're laughing. Did you smoke a Gaulois? What was it like? Okay. Anyhow, here's my point. He was smoking Gaulois, right? So Gaulois was not immediately available in New York City where he was doing residency and fellowship. Okay? Actually, a smart guy. He did internal medicine and pathology. So he switched to a low-tar nicotine substitute called Marlboro. And he was smoking 6 packs a day of his low-tar nicotine substitute called Marlboro to replace the amount of nicotine that he was getting on a box of Gaulois. Okay. Now, eventually, when I met him, he had titrated himself down to 2 packs a day of Marlboros. And eventually he got himself down to like 2 packs a day of Parrots or Carltons or something that was actually half cabbage. Okay? Now, what happened was Mario doesn't drink. But we were sitting in this restaurant, and Mario ordered a beer, and then he pushed it aside. And then he ordered a cup of coffee. And the beer did something really funny. It got warm. I'm grieving over that beer to this day. You can tell what my diagnosis is. And he said to me, Dave, I'm going to die of a tobacco-related illness. And I said, yes, Mario, you're going to die of a tobacco-related illness. He said, Dave, I'm a board-certified internist and a board-certified pathologist, and I can't stop. You're an addictions doctor. What do you got to help me? And I put him on the anti-smoking craving drug of the day. I put him on a nicotine patch. Now, this is a guy that doesn't drink. And the funniest thing happened. What happened was he quit drinking or quit smoking. I gave him the text to AA to read. I said, whenever you see the word alcohol, substitute the word nicotine. So 3 days later, he called me up and he said that his wife had read the book and diagnosed him as alcoholic. I said, that's very nice, Mario. And he had also decided he's also alcoholic. I said, Mario, I don't know if you've noticed, but alcoholism normally requires the presence of drinking. You don't drink. He said, I know, but I got the disease of addiction. In other words, he was able to transcend the labels and just could understand the concept. He said, do I have to go to meetings? I said, no, but you do have to stop smoking, and you're going to have to internalize the stuff that you've been reading about and make a few changes in your life. And he said, okay. Now, so Mario quit smoking. 4 weeks later, he called me up and said, Dave, I went deep sea fishing off the coast of North Carolina. I said, Mario, that's absolutely great. I think that's wonderful. He said, Dave, on the second night, I smoked a cigar. I said, Mario, this will not end well. He said, no. Dave, I never smoked cigars, and I didn't inhale. I mean, that's like an alcoholic refrain if I ever heard one. You see what I'm saying? I mean, the guy doesn't drink, but he's talking like an alcoholic. Right? The point is, he's addicted to nicotine. He's as addicted to nicotine as anybody you have ever seen addicted to fentanyl. It's just what is. I said, Mario, you do whatever you want, okay, but this is not going to end well. It will not end well. Now, call me up and tell me how it goes. Now, what's interesting about this story is that Mario hates fishing. You get him near a puddle of water, he gets seasick, and he can't stand the taste of fish. Okay? He called me up 2 weeks later and said, Dave. I said, Mario, how you doing? He said, Dave, I got to talk. I said, well, okay. He said, you won't believe what's going on. I said, what's that? He said, every night when I go to bed for 8 hours, I dream about fishing. Now, if you can understand that story, you can understand addiction. This poor gentleman went to bed at night abstinent from nicotine, and after a few days, he was getting fishing dreams. Why was he getting fishing dreams? Last place the brain saw nicotine. So you can see how all of these structures are now hooked together. Okay? So what we have is the higher executive functions here in the frontal lobe of the brain, okay, hooked onto the nucleus accumbens, hooked onto hippocampus, which has to do with spatial memory and other event memories, coupled with amygdala, which is emotional memory. And if you drink and drug long enough, you damage the frontal lobes of the brain. Which is why you see a surprising lack of insight and sometimes a lack of recovery of cognition in the brain with people that are addicted. Okay? Now, the brain has tremendous restorative properties, but sometimes you see them and they're just a little too far gone. especially with alcohol. Here's the psychiatry oral board question that they sometimes give you in the oral boards in psychiatry, or at least they used to. I'm not a psychiatrist. And what you do is test for confabulation. What that is in extreme alcoholism, first you get Wernicke's encephalopathy, and that progresses to eventually Korsakoff's if they keep drinking, especially have no thiamine. What happens? They lose retentive memory. So what happens is if you talk to them for 30 seconds, they make sense. If you talk to them for 20 minutes, you realize that they're bonkers. What happens is the brain fills in stuff that it doesn't know, and it just makes stuff up, which is called confabulation. The classic board question in psychiatry is, what color is this string? The correct answer is there is no string, Dave. What are you doing? What's wrong with you? That's the correct answer. When somebody says it's blue, that's Korsakoff's. Okay, that's why that happens. Okay. Now, in that we've established that this is a genetic disease, at least half of it, what are you going to do about the genetics? How many different spots on how many different chromosomes? I would posit that it's a big number. In fact, science actually bears that out. Looks like at least 50 genes. Okay? So if you do the number of permutations of 50 times 49 times 48 times 47 times 46 all the way down to 1, that is a very big number. That's all the different flavors genetically that you could have of expression. That's why when an alcoholic or an addict feels like they're terminally unique, okay, they actually are. Don't tell them that. Okay, there's more similarities than there are differences. Okay, now also remember that the penetrance of whether these things get turned on or off, the expression of these things can be anywhere between 1% and 100%. Now, if you start tinkering with that much of the human genome, you might be able to do it for some of it. But I'd be a little surprised if you get an immediate genetic knockout in my lifetime. I mean, like you take some genetic soup from a rat or something and splice it into the human DNA and like you're done. I'm a little afraid of that one, okay? You might get like furry ears and a tail and a craving for cheese at 3 a.m. I don't know. Maybe, maybe not. It's too early to know. So you really don't have a genetic thing on the horizon in the immediate future that I know about. The next thing is, what drugs do you have? Well, in the case of opiates, you have methadone, buprenorphine, and naltrexone. Naltrexone's a blocker. It works better if you give it IM once a month. Okay? What happens with buprenorphine? Sort of an agonist-antagonist, and it will have a ceiling effect at about 24 milligrams. It would equal 40 to 60 milligrams of methadone, roughly. Okay? That means if you take a lot more of it, you won't have much more of an effect. Methadone is a full mu agonist with no upper limit. What's the whole problem with opiates? Why do we even worry about opiates? People die. Why do they die? They don't develop a tolerance to the respiratory depression. They do develop a tolerance to the euphoria. That's why that happens. Okay, so what do you do with methadone? What it is, you put them on a high enough dose that if they happen to shoot 5 bags of heroin, they're wasting their money. To a lesser extent, that's what happens with buprenorphine. But notice what you're tinkering around with is sort of the limbic system of the brain. So all I have as an addictions doctor is something to tinker with that drug craving, you know, sort of alligator crocodile function. I don't have anything that works on the frontal lobe of the brain. I mean, is there anybody in this room that has an honesty pill that they'd like to share the name of, the brand name? I mean, I know we're supposed to use generic names here, but I mean in this case, how about an integrity pill? You got one of them out there? Anybody? How about doing the next right thing pill? You got one of those? I don't think so. I didn't think any of you'd have one. I mean, and I don't have one either. I mean, it sounds like I'm making fun of this stuff, but I'm not. My point is that you're going to have to change the frontal lobes of the brain. We're going to pretend that those are fairly normal frontal lobes. Okay, you're going to have to change around these executive functions, which is why they look so wacky, at least in early recovery. Even if you quell the cravings for drugs, they're going to act a little strange for a while. Why is that? Frontal lobes of the brain, the executive function is all screwed up. And if it has gone on from childhood, that's a lot to unscramble. And that's why the talk therapies seem to be of some help. So if you just give someone buprenorphine or you just give someone some methadone, I think that's probably a good idea. Why do I think it's a good idea? Number one, they may live. Number two, you may knock down some of the risky behaviors, and you may decrease the incidence of hepatitis C and HIV. Number three is you're probably going to benefit the community by knocking down crime and other behaviors, right? But you might not do too much for the type of thinking. And the problem is the thinking, I mean, here's how wacky the thinking can get. I got called to the ICU. I gave a talk to the hospital where I used to work in Western New York to the medical staff on addiction. And no one there had ever diagnosed alcoholism or addiction that I know about in the time that I was there, and I was there for like 15 years. And here's the problem. I was using the Dave Withers addiction screening test, okay? Now, the quick and easy addiction screening test is the Cage questionnaire. Has anyone asked you to, have you ever had to cut down on your drinking or drugging? That's the C. The A is, have you ever been annoyed by someone talking to you about your drinking or drugging? The G is, have you ever felt guilty about your drinking or drugging? And the fourth one is, have you ever had to have an eye opener or a morning dose of a drug to stave off the shakes or withdrawal? That's the normal Cage questionnaire. Okay? Part of the problem is, and this is the only disease that protects itself, so it presents late. And as clinicians, we don't ask the questions. Now here's the Dave Withers emergency medicine screening exam. I don't use a screening exam anymore, okay? The first one is, if you open a fresh fifth of bourbon, do you throw away the cap? Question number one. Question number two screens for drugs. Have you ever had a pre-employment drug screen come back positive for pesticides as a drug of abuse? Okay? Question three screens for grandiosity. Have you ever gotten into a fist fight with a priest at a wedding reception? The fourth one screens for unmanageability. Well, that's on the unmanageability question. The grandiosity one is, would you quibble with the following statement? Incoming artillery fire has the right of way. Okay? So here's my point. My point with all of this, I'm poking fun at it, but in other words, unless you ask the questions, you're going to miss a lot of this stuff depending on what screening test you're going to use, because the nature of the disease, remember what I said when at the beginnings of this talk. What I said is it's characterized by a denial, and the denial structure will eventually take on a delusional quality to it. So I was called to the ICU as an addictions doctor to see this gentleman that the three surgeons were clustered around the phone trying to figure out if the guy had alcoholism. Now here's what happened. What happened was there was a guy 3 stories up on a roof pitched like a steeple at 3 a.m. drinking a 30-pack of beer with his dog. Okay? He got halfway through the 30-pack of beer and the inevitable happened. He passed out and he fell 3 floors down, okay, and both femurs were sticking through the skin like that, and then he broke his pelvis, ruptured his bladder, ruptured his spleen, ruptured his liver. And what happened was the neighbors were awakened by the dog on this very steep roof who was there, and they walked out and they saw a dog on a roof and thought, this is nuts, and then they looked down and they found 20 beer cans and a pile of blood and this thing all screwed up in the center of it, and then they figured it all out and called EMS, and they showed up, and so the surgeons took him to the OR and they fixed all that stuff. And so I went to see him and I said, sir, do you have trouble with your drinking? And his response to me was, no, I have 2 broken legs. And that was his truth. That was his truth. He actually believed that. If you put him on a lie detector, he would have passed. Okay? So it has this delusional quality to it. If you drink and drug enough, you'll believe your own, the brain has to believe in something. And it'll make up its own falsehoods. It's really fascinating. And guilt and shame don't help too much either. I've never had anybody walk into my office and say, Dave, if I only had a lot more guilt and shame, I'd feel a whole lot better about myself. I've never had that happen. Okay? And by the way, as we talked about the hole in the soul through which blows the cold north wind of life, what is the insulation? The drugs or the alcohol, the benzodiazepines, the heroin, the whatever, the alcohol. Do you see what I'm saying? So that works as the insulation until it doesn't. Well, this makes no sense at all, Dave. If drugs and alcohol are the solution to my problem, then how can they be the problem? Well, that has to do with the progressive nature of the illness, where the solution that is sought to all of this emotional uncomfortability creates more debris. Now you're in a position where you can't drink and drug, and you can't not drink and drug. Folks, that is called a dilemma. You stuck. What happens then? See, and people are very, very baffled by this, and so is society. It's very clear to me. You try explaining this to your run-of-the-mill judge or something, and they take a very dim view of this, okay? Not so much in drug court and that type of stuff. They understand this type of stuff. And if something has been done to society, I understand a penalty has to be extracted in return for that. I got that part very clear. But if it's a drug or alcohol-related offense, I respectfully believe that treating the alcoholism or the drug addiction probably is the correct solution with a carrot and a stick, which is what drug courts do. Okay? I mean, they actually work. Because it's very rare that somebody just has a sudden rearrangement internally where it all becomes clear and they stop. That may happen for somebody that's 20 that only got in trouble once. If this goes on for decades, not so much. I had a guy walk into my office, and he was sort of an interesting guy. This is back when I was at Marworth. You know, and he was sort of an angry guy. Why are you here? Judge sent me. Okay. Why did the judge send you? Got arrested. For what? Drunk driving. Well, why did you get arrested for drunk driving? The cop was a jerk. Okay, but I mean, if you take this apart, I mean, it sounds a little absurd right now. I mean, this is pretty close to what happened, okay? I mean, there's a little bit of exaggeration in this, but not much, all right? Now, here's what actually, if you think about it, what happened is that had become his truth. He actually believed that. This is very warped and this is very twisted. Frontal lobes of the brain were damaged, and that was his truth, okay? These are the types of things that will not resolve themselves spontaneously, especially once the disease really gets going. And the screening test that we used, which I demonstrated to you, at least the one that I used to use, is or the equivalent of that, is analogous to the way that we approach these types of patients. So that the questioning has to be a little bit more subtle because of the guilt and shame aspect to it. You have to understand that denial and outright delusion may be part of the answers. Okay, and you might have to, as Michelle Kay was talking about just a little bit ago, a couple hours ago, that when you first ask them if they've ever had legal troubles, they would say no. And then you ask about DUIs, and the news comes out, and you finally get to the bottom of the story, and it's 5 years in prison or something. Do you see what I'm saying? So if you just sort of go through and check off the boxes as fast as you can, you will not get to the bottom of this one, which will be maddening to most healthcare providers. The nature of this disease is, in general, when you put somebody with chemical dependency in a room one-on-one with a clinician, you have just handed the reins of control over to the addict. And the reason is, to pursue that addiction and for the frontal lobes of the brain to get what it needs, one has to go through extraordinary measures each day to achieve that. Okay? So it's a 24/7 type of deal. Probably been going on for a decade, maybe 2 decades. And I mean, that's like several PhDs worth of work, folks. You think you're going to creep up on that one? I posit that you can, but I respectfully believe it will take a bit more thought. Okay? And because our screening tools usually are inadequate, and usually in the way that we apply them, I'm just talking about in Dave's emergency medicine practice. That would be like screening for rectal cancer by asking about pencil-thin stools, right? Or diagnosing breast cancer with a fungating breast mass. Can we agree that those are not terribly sensitive indicators? Okay. And so you have a disease of secrecy and deception that the individual may or may not know about, along with all of these other factors, and what you end up with is today's drug epidemic in America. And right now it seems to be heroin, and it's like the third drug epidemic. The first one happened shortly after the Civil War. Why? The treatment for open fracture back then was amputation. Basically, any gunshot wound of an extremity frequently resulted in an amputation and all that phantom pain plus all the PTSD. Remember back to the hole in the soul type of thing. What is the purpose of the insulation? It's to insulate against the cold north wind of life. Morphine does that very well. As Chris was talking about just before this talk, if you wish to think about it a little bit more when you're talking about chronic pain, what exactly is the lesion and what are the modifiers? Morphine may relieve the pain of a bad marriage. Morphine may relieve the pain of depression, at least for a little while. It's an imperfect solution to a problem. Do you see what I'm saying? I think that that's probably why you end up with a lot of bad surgical results. If you take people over the age of 50, a surprising number of them will have positive CT and MRI findings, okay, at least of the spine. But if you ask them what's going on, if you take normal people and you just do imaging on them, you're going to find all kinds of stuff. The thing is, they're asymptomatic, okay? But you end up with our population, what you may end up with is they have positive findings on the MRI or CT, okay? And then you have all these modifying things in there, and then the case starts to run awry, which is why you sometimes end up with, and I'm not saying all the time, people may end up with 2, 3, 4, 5 procedures, and the problem is worse, and now they're on a huge dose of morphine or whatever, and you're scratching your head. What happened? Probably could have used a little bit more work on the front end, okay? I suspect that these types of things are the challenges. Now, regarding the hole in the soul, I may be able to relieve the cravings for drugs, in the case of opiates, with buprenorphine or methadone. But it doesn't do anything about shrinking the hole in the soul. The challenge, ideally, is to shrink the hole in the soul so that there's nothing for the cold north wind of life to blow through, which is then called recovery. The cold north wind of life is not going to stop blowing for anyone in this room. We're all going to experience losses. So is the rest of humanity, just the way that it is. Cold north wind of life. The challenges of everyday life and sometimes the extraordinary challenges of life, okay? But if there's nothing for the cold north wind to blow through, then the analgesics are not needed, which is called recovery. So that's why it's sort of a couple different facets to this one. I'm about out of time. What I would like to say is that it's been a profound honor to be able to speak a little bit today. And what I wanted to do is just talk about it in a thoughtful way without it getting real confused on a whole bunch of neural pathways and a bunch of stuff, you know, with neuroanatomy and like that. I almost think the cucumber and the limes and the oranges are a little more memorable than, you know, because the neuroanatomy and the neurophysiology of this stuff is being sorted out, as is the neuropharmacology. The thing is, it's really complicated. And I respectfully believe that that's not going to help any of us in this room diagnose their next patient and get the next one to treatment. So addiction is, number one, it's diagnosable. Number two, it's treatable. Number three is it shouldn't be so exasperating, I would hope.